Hello, my name is Jenna and today I am going to be your nurse. I am going to be performing a full lung and cardiovascular assessment. So the first thing that I'm going to do is the lung assessment. I'm going to inspect the anterior chest, looking at the size and shape of the chest wall. I want to make sure that the AP diameter is about half to the lateral one, which it is in this case. I also want to look for any barrel chest, which could mean COPD. I also want to look at the ribs, making sure that the ribs are at a downward angle and not horizontal, which they are in this case. And then I want to look for any signs of distress, so any tachypnea, any cyanosis, and any retractions, which I don't see on this patient. And then I want to just note the rate and the rhythm of the respirations, and also the color and condition of the skin on the chest wall. All looks well in this patient. Next, I'm going to palpate. So I'm going to take my two fingers and I'm going to lightly palpate the patient's chest, and I want to feel for any crepitus, which is any Rice Krispie or popping or crackling sounds that I might feel. So I'm just going to lightly palpate, and I don't feel any, but if I did, I would indicate that could be subcutaneous air. Next is percussion. I don't actually percuss because typically percussions are not done at the patient's bedside, but the point of percussion is to listen for resonant sounds, and that is the normal sound that you want to hear. You might hear any softness or some dullness on the liver or abdomen, which is normal, but again, you want to hear resonant sounds when percussing. And then lastly, you want to actually listen for breath sounds with your stethoscope, and that is called auscultation. And so you want to hear each breath sound for one full inspiration and expiration at every site, and typically it's done best with a bare chest, but I am going to be leaving the patient's gown on for this video. But again, you want to listen at each site for one full inspiration and expiration. And the three breath sounds that you want to hear that are normal are bronchial, and that is heard at the upper airways, and that is a high pitch, and expiration is longer than inspiration. The next is the bronchial vesicular sound, and that is heard at the middle airways, and it's a moderate pitch, and inspiration and expiration are equal. And then the last one is vesicular breath sound, and that is heard at the outer airways, and it's a low pitch, and inspiration is typically longer than expiration. And any abnormal breath sounds would be any crackling, any wheezing, any pleural friction rub, or stridors. So I'm going to begin by listening at the top of the lungs at the apex and making my way bilaterally, symmetrically in the same manner across the anterior chest. And so each time my stethoscope moves, I'm going to have my patient take a deep breath. So each time you feel this move, please breathe in and out.
Okay.
Here we go. Great. Next, I'm going to move to the posterior chest, and so I would inspect the same way. I would also palpate the same way with my two fingers, and I would feel for any crepitus. And then I would also perform the tactile Firminis test, which is when I take my hand and use the palmar part to feel for vibrations. And so I'm going to have the patient say 99 5 times to feel for vibrations. So please say it.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
Great. And if you feel a lack of vibrations, that could mean fluid in the lungs. Next is actually the auscultation part again. So I'm going to put on my stethoscope, and I'm going to start at the apex of the lungs and work my way bilaterally and symmetrically to hit all points of reference on the posterior chest. So I'm going to have my patient breathe each time he feels my stethoscope move. Please breathe. Again. 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 Great. Okay, so now I've completed a full lung assessment. For nursing concepts, I would just indicate any abnormal breath sounds on my documentation, and then I would also remember that I can use my interventions such as turning, coughing or deep breathing, or the use of the incentive spirometer to help my patient get air in their lungs if needed. And I can also send for oxygen or for a chest x-ray if I felt that was necessary or needed. Next is the cardiovascular assessment. So first I'm going to inspect the patient's upper and lower extremities. I'm going to be checking color. I want to look for hydration status, and I want to look for any edema that might be present. So I can do that by checking the color, and I don't see any blueness or any redness, so that's a good sign. I can check the capillary refill time, and again, I can look for any edema, which I do not see on this patient. Next, I'm going to actually palpate. So I'm going to use the back of my hand, and I'm going to palpate the patient's skin temperature, and I'm going to indicate any sweating or any moisture, but all feels normal. And then I can also actually assess for hydration by performing the skin trigger test by pulling up on the patient's hand and releasing. And this patient looks hydrated and no abnormalities as far as skin condition or color. Next, I want to actually palpate for the peripheral and central pulses. So I'm going to begin by using my 2 fingers to palpate the carotid artery. And then I'm going to palpate the radial artery, the ulnar artery, the brachial artery, the femoral artery, the popliteal artery in the back right here, and then having them place their foot up on a stool, I'm going to assess the posterior tibial pulse, and then the dorsal pedal pulse at the top of the foot. Okay. Next, I'm going to actually auscultate or listen for the breath sounds. So I'm going to use my stethoscope and hit all 5 points of reference on the anterior chest. So the first is the aortic valve, and so that is found at the second intercostal space to the right of the sternal border. So right here, I'm going to use my diaphragm to listen for that lub-dub S1, S2 sound. Next, I'm going to go to the pulmonic valve, which is to the right of the sternal border at the second intercostal space as well. Next, I'm going to go to the Erb's point, which is the third intercostal space. Next is tricuspid at the 4th intercostal space. And finally, we have our mitral valve at the fifth intercostal space, mid-clavicular line. And here is where we hear the apical pulse, and so we want to assess for 1 full minute to make sure that our patient's pulse is in normal range of 60 to 100 beats per minute. All looks good. And then next, we would just flip our stethoscope and use the bell side to hear any heart murmurs in those same locations. So I'm going to hit all 5 points of reference just to hear any murmurs, if any were to be present. And I don't hear any heart murmurs. And then lastly, I would just want to document that I took the patient's blood pressure in a previous video, and the blood pressure was in normal range of 120/80. And that is it for the full lung and cardiovascular assessment. I would perform hand hygiene, and then I would thank my patient. Thank you. And that is all.